Yeah. Okay.
All right, Jim, you can open up.
Okay, welcome everybody to our meeting of the coalition. We have a small group, but I know it's probably the most important people in the state are on this call right now. So I appreciate you giving us your time on Friday to hear about what's going on. You know, clearly we're in a time of transformation, and in times like that, getting as much information, real information about what the environment is currently is critical. And I think this is where the coalition has played a very important role. So with that, thank you again for joining us. So I want to first start with talking about the board retreat. As many of you know, that the board gets together every year in July to talk about what are the important issues that the coalition should be focusing on in the coming year. And so at that time, we hear from some very important people throughout the state or throughout the region who can inform us about what's going on, but also help us drive our priorities. And so this year, I think, was especially successful because of the people we were able to come and speak to us at the retreat. First and foremost, it started with Jason Helgerson. And Jason clearly is the guy driving the train here in terms of Medicaid reform, besides the governor, but probably even Jason. And what was especially gratifying to hear from Jason is how he has really understood the importance of early childhood and children's services in bending the cost curve of Medicaid. And Jason talked to us about some of his priorities related to children. And in many ways, he was saying what anybody who's been in the field for any length of time has been saying for a long time in terms of why doesn't the state do this? Why don't they think about prevention? Why don't they understand that if they invest in children's services, that we can make a difference in the long-term health of populations? And Jason really kind of presented that and really did an unbelievable job in talking about how Medicaid managed care will go forward as planned, regardless of what takes place. But he also is pleased with the implementation of what's happening in health homes serving children. It's a little bit slower than I think we want, but I think he's happy, and he also is committed to making sure it is successful. We talked about VB, value-based payment readiness, and he also said that the children's system will be involved. And so anyhow, Jason talked again, finally, about his initiative, the first 1,000 days. And it's really about focusing on the 0 to 3 population. And again, it's really music to the ears of anybody who's worked with kids for any length of time. And so I thought that it was a great way to kick off our retreat. Coincidentally, we had a call from the governor's office, and Jackie was invited to discuss the coalition's priority before the governor's staff. So, you know, there was a lot of excitement and a lot of belief that the coalition is really earning a lot of respect within the state. And so that was a critical part of the board retreat. We also talked about moving forward with regulatory reforms, integrated care, telepsych committees being monitored, We had an American Academy of Pediatrics representative talk about linkages between our providers and pediatricians to integrate care. And we had representation of the Managed Care Association also talking about the need to have discussions with the plans and showing that we understand what DOH expectations of plans are and how we help the plan meet their metrics. So again, there was a lot of high-level conversations about what's happening in Medicaid managed care and how it impacts children. So it was a very exciting retreat, and from that, we really talked about some of our budget priorities, which I think is on the next slide. And if you see that, we can't do any of this work without a competent and capable workforce. And so we know that the state has really not invested until recently in the workforce. And we really made an agreement that that has to be a priority, that none of this happens without a stable workforce. So that's number one. What also doesn't happen is if we don't have the resources to really deal with the Medicaid managed care environment. And that means there's some need for readiness funds and IT funding that, some of, the other sectors have gotten multi-millions or billions, and the kids have not really benefited as much as we needed to. And so that's going to be a priority. We really need to kind of hit that hard with both the governor's office and with our partners, and then be ready to do the same with the legislatures. And then also talk about value-based payments, because that's really where the direction of Medicaid redesign is going. And I think Jason believes, and I've heard this, that even regardless of what happens in Washington, value-based payments is really going to still be a priority. And I guess the only exception would be if Price, who's the, I think, HHS director, kind of gets his way. But I think value-based payments is really something that there is money available. We have to really work closely with the state to develop some projects so that we can demonstrate, A, that we are committed to working with the state, and B, that we want to learn some of the things that need to happen to improve the outcomes for kids and families. So that's going to be our priorities. And then finally, we had, again, meeting at the retreat, Marlene Radigan, who anybody who has heard her speak at either a coalition conference knows how competent and how really what an expert and what a partner to have in terms of understanding our population. And she really is willing to work with us to develop a proposal on data access. And we have some trends that I think Marlene...
Marlene provided us, after we spoke at the retreat with Donna Bradbury and Emil about wanting to work on data analytics, Marlene was permitted to put some information together and share with us. And Nicole, if you could just put up that first group of charts, because the board felt very strongly that we have to strengthen our capability to work. Oh, do I have to unshare my screen first? No, you can.
Nope, I've got it. Here we go.
Okay. So Marlene was able to share with us some trends in residential utilization. So you see that the utilization is going down in both RTFs and community residences. If you could go to the next one, Nicole. And then she gives us a table format of the same information. And everyone got these documents. And then the next one, Nicole, she shows us the trends in the state PCs and private psych hospitals, which is no trend at all, apparently. And then you can go to the next one, Nicole. Again, whole numbers. And this is a 3-year period. And then is that the end, Nicole, or is there one more page?
Nope, this is it.
Okay, so I just wanted to share those because the indication, you know, the coalition is you know, has to determine, you know, which direction we want to go in analytics. And I think the board, Jim, correct me if I was wrong, tended towards thinking partnering with Marlene because she's doing database development for the value-based payment pilots seemed like the best bet.
Yeah, and I think that's true. And because she really understands, I think, data in a way that not too many people do. And I think the issue really for Marlene is really one of resources. And so, you know, there's a sense that if we can get the leadership of OMH, the commissioner, to really make, to provide some resources or to direct Marlene to work on this, that it would benefit our providers. Is that kind of how you understand it as well?
Yeah, that we are going to pursue having some of the technical assistance money that the state's already contracting with different subcontractors to use it to put another person in Marlene's staff that'll just be dedicated to producing information related to the children's system and then sharing it with the providers, and even allowing the coalition or individual providers to request specific reports that we could then have access to and Marlene could put together. So we are having that discussion with OMH, and that came out of the board retreat.
Yep. And so, you know, before we go on to the next, I'm wondering, Nicole, if we can ask people who are on the call, who are at the board retreats, if they want to add something, to raise their hand so you can unmute them, or if you have a question.
We do have a question from Kimberly Kazioka. She comments, it would be interesting to know how many of those admissions are readmissions by the same children versus new admissions.
Yes, Kim, that is exactly the type of thing that Marlene does so well for us, and that she has access to that information. She keeps that information, and she has cut it for us before. But it's a perfect example of the type of ongoing data that we would like to be able to request maybe monthly, you know, from our Marlene, if she had the staff resources and we weren't just, you know, it's not just her. You know, if there's someone designated or, you know, to work with us to have monthly reports or something of that sort, quarterly reports. Excellent question.
If anyone else wants to ask a question, please type it in the chat box, raise your hand, and I can unmute you. Not seeing anything yet, so if you guys would like to move on, we can move
Yeah, why don't we? Yep. Okay, the other thing that's important that the board determined, we're going to, you know, as you know, we've had a staff sharing agreement with the New York City Behavioral Health Coalition, and we agreed to continue that through November. That's number one. And number two, to really to work hard on requesting cross-association collaborations to strengthen children's advocacy efforts. And really, the goal is to really strengthen the impact of children's voice, that we don't believe that there is anybody who really are speaking for kids in a very forceful way, in a voice loud enough to overcome what you hear from the hospitals or what you hear from the adult providers, that the kids are really poor cousins to all of those. And if we really want to be effective in our advocacy, we really have to work together with some of the other children serving coalitions. And so that's something that the board has continued to push, and will work on that and keep the rest of the agencies up to date about what's going on in that realm. And then finally, we talked about transition or succession planning. As you know, the coalition really depends on two very competent and capable people who have just been doing an amazing job for us. But when you compare it to what you see in other coalitions, we get a lot out of two people. And if something were to happen to either one of them, we'd have to scramble and make decisions sooner rather than later. And that's really came to the forefront because Andrea is running for county executive in Rensselaer County. And so the board kind of said, uh-oh, we better start thinking about it and think about what we need to do in case she wins. And we certainly would have two feelings about it. We'd feel good for Andrea, but we'd also realize the loss. But I think it's also important as an organization that we do spend time thinking about transition and succession planning, even if this was not happening. Because again, we all know that anything is possible, and when you rely on such a small number of people, we have to be prepared to respond if something were to happen. So we've developed a small group of people, and it consists of Lenny and Terry, Karen Richmond, and myself, and Jackie is leading it, to really talk about transition issues, succession issues, and talk about the future leadership of the coalition. And so we are think it's important for any organization to have those conversations, and we also think it's especially important for the coalition, given what's Andrea's plans or hopes to her election. So that's, I think, important. We don't know what's going to happen with Andrea. We wish her all the success. We wanted to make sure everybody understands that that's what she's doing. Clearly, if you're on Facebook and you like her, you know that she's doing that. And so we want to make sure that the coalition is prepared and is as strong as we need to be in case something happens. I don't know, Jackie, do you want to add anything? You've been leading that for us.
No, I think you've covered everything, Jim, and we just want to assure the membership that should Andrea win in November, that operations will remain the same, and then this transition team will take a look at what may be needed and is in the best interest of the coalition to for the future. But as far as transition, our teams will remain intact, and we'll be putting more time in to make sure that the coalition gets through a successful legislative session, and also conference and other activities will remain as usual. So I think Jim just covered it. The transition team's looking at different scenarios, and I just want to add that the board's been discussing this at their retreats the past couple years, and they have teamed up with, some of the different associations and taken a look at where we could share collaborative services. One being with New York City, we're doing a lot more with Families Together, et cetera. So because of these conversations that the board has led, it has strengthened partnerships and collaborations for the coalition over the past couple of years. And I think we're confident as a team that we'll be able to continue with the quality services for the members as we have in the past. So that's it.
Hey, thank you, Jackie. So that's it for my report. And if there are any questions, raise your hand, type them in, and if not, then we'll go on to the next item.
So Nicole can look for some questions and also put up the next document, Nicole, which is just a multi-page draft of comments that are due today on the transition plan for the children's system to Medicaid managed care. And I think the kind of sudden release of this on August 15th and the fact that the state originally wanted comments back by August 31st, was troubling, but it reiterated the message that we heard from Jason, that the state feels very strongly that moving the children's system under the 1115 waiver authority is the best protection against Medicaid cuts. And so the pace of the transition will not slow down. And the coalition's comments that I've drafted here try to support the premise of the transition, but raise the issues that we're facing. And so I think the first comment is kind of the universal concern. The goal of the transition and the goal of the kids MRT has always been to prevent escalation to higher end services and address needs earlier. But we're at the point of transitioning to a program that will start to do that. But we have kids in care right now with high needs. And it really does feel in this transition plan that we are moving kids who are getting intensive services in our existing waiver program into health home without the spa and new waiver services being available. And so we're kind of cutting the safety nut out from underneath kids and families. And, that's kind of the premise upon which most of these comments are made. We get into the details about some of the provisions of the transition plan. We talk a lot about the need. Nicole, you could scroll up a little bit, about the fact that there are very weak descriptions of the rates or the caseloads in the different transitional sections, that there is no concrete discussion about what the independent entity is, although there's a lot of description about what their responsibilities will be, and it feels very much as though the responsibilities are muddled. Like, is it for certain populations? Is it for all kids? Is it for certain circumstances? Is it for any circumstance? Because if it's for all circumstances, it feels very duplicative of things that others are supposed to be doing in the system. We spend a lot of time, and our family members on the preparatory call earlier this week, we spend a lot of time on the consumer education piece being not sufficient. And especially the fact that if your staff are supposed to be the key educator of how to transition the services and how to enroll in Medicaid managed care, and those are not billable services when your staff is in the home or meeting with people, then we cannot maintain productivity and do a good job educating people. So I think in a nutshell, that's kind of the the comments, but I did send out the document. It is not due until the end of the day today. So if anyone has suggestions or even edits, because I'm the author and editor, thank you, Jim Nyreen, because he caught a couple of things. You know, there are some proposed complex billing transitions where we're going to be billing for crosswalk services and not the actual services. And given the fact that this week there was a complete acknowledgement that the care management assessment billing was flawed under fee-for-service, we asked for test claiming even before we go to managed care on the fee-for-service interim rates to make sure that things will work and we're not going to be caught not getting reimbursed and then find out about it 2 months later and have to do an emergency fix. So that's another point that we make in the transition comments. So that's it, Nicole. You can go back to my screen and then see if anyone has any questions. Thank you.
So we do have a question. Hold on, let me see. From Elizabeth Nolan. She asked, good point, excuse me, I'm not sure of the HFW, but if they include it when they need to provide funding through a higher rate than the current high acuity rate, not possible otherwise. Elizabeth, I'm going to actually unmute you so if you want to comment further. Here we go. On your question. Liz?
Yep. Can you hear me?
Yes.
So, Andrea, as you know, we're all totally supportive of high fidelity RAP as an intervention, but initially they had spoken about a higher rate than the high acuity rate, and that went by the wayside. So if we're going to mention high fidelity rate, I think we just need to add that they need to fund it.
Right, and I did ask a couple of people at OMH to take a look at these, and one comment back is, I indicate that high fidelity RAP is completely off the table, and they say that it's not, but I'm surprised by that because, you know, as you're mentioning, even if it's on the table, it's not on the table at a better caseload or better reimbursement rate. So it's, to me, that's off the table.
Yep, I agree.
So I will clarify that a little bit more in my comments before I submit.
Great, thanks.
And Fern, I see you have your hand raised and you asked a question, but you're welcome to ask it aloud. I just unmuted you.
Okay, I was on the, thank you. I was on the call where we had some discussions, and there was some concern about the eligibility criteria, and I know that that had been discussed with CMS before, but still very concerned about where kids with substance abuse disorders, where they fit in, and concerned about their eligibility for health homes and home-based services. It's really not discussed at all, and they're not on those last pages where they talk about eligibility.
Right. I'm sorry that that didn't make it into the draft, but I will make sure that's added. Thank you, Fern.
Okay, great. Thank you.
And I think that you, yeah.
Hello?
Yep.
Oh, okay.
Anything?
Sorry, I thought I was.
No.
That was the primary concern. I'm still, you know, separately, I get confused about the difference between level of need and level of concern, and what that means in terms of eligibility for services. I don't think that was really fleshed out.
Yeah, I always get confused.
I know. The state uses, I did make a comment to the effect that if the state wants to make references over and over again, they need to reiterate the basic understanding of it with, you know, every time. I said this about the independent entity and what populations they're really doing it for, because they started to just slash health home manager independent entity. Well, is it both? Is it one? Is it the other? Is it under certain circumstances? Like, we're not as familiar with these things, and we're not operating them to be able to understand the nuances, you know, every single time. And I know that the chart tries to differentiate between level of need and level of care, but I agree with you. It's very difficult because one really has to do with eligibility at all, and the other has to do with eligibility for certain services. And it is never completely clear which one is which and which services are subjected to the level of care determination and which services are just available to Medicaid eligible kids. And I think that that has to be clarified before we get to an operational level.
Yeah, so that was one comment. The other suggestion was that they include a glossary, because they are going back and forth, and there were a couple of terms in there, some acronyms that I just didn't know and they never defined.
Yeah. Right, the cover letter will have a request for flow charts, scenario descriptions.
Right, that was the suggestion. Right.
Yeah, we'll put that in the the message that gets submitted.
Great.
And what's important for everybody to understand, that the state is really committed as much as they can be to the time frames, and the time frames are very tight, and many of us question their doability. But so really commenting and understanding it and being able to coordinate through Andrea or Jackie what our concerns are, and we need to keep that message clear and consistent, because this whole thing could blow up in front of us if we don't.
As long as I'm still unmuted, one other comment around the training. I think it was very important that we talk about the amount of time staff time that will be involved in doing this, but also that we be trained on how to provide the information consistently and accurately to our staff. That there need to be materials that we could use to our clients. I mean, there need to be materials that we can teach our staff to use so that they can communicate effectively to our clients. Does that make sense?
So management level training as opposed to
well, you know, whoever is going to be communicating with the clients about these changes, you know, it's one thing to talk about that this is an unfunded mandate, you know, that it's going to be costly to us to have to do it. But given that we will be doing it, we need to be properly informed and trained, and we have to be armed with some materials that we can share with our constituents, with our clients, that's accurate, so that we're not making it up as we go, we're not getting it wrong, we're not filling in the gaps and giving misinformation. There has to be consistency.
Okay.
So we did have another, oh, sorry, we had another hand raised.
No, go ahead.
Lisa, I've unmuted you. Lisa Kinney, can you hear me? All right, well, she's unmuted. We can return back to her. We can't hear you. Okay. We can move forward. Maybe she'll hear us.
Okay, Lisa, you could, yeah, and Lisa
Oh,
could
she's
type
lost
in
audio. Okay.
Okay.
Sure.
So just to make summer fun, the first transition that many of our provider agencies had to go through was the September 1st deadline for unbundling and meeting the conflict of interest guidelines that CMS imposed on our home and community-based waiver program. You know, we have been having discussions with OMH about the waiver transition for so long that when they sprung it on us in July that September 1st was the date, it didn't feel real. But it is real, and it has been real. And it was met with a complete surprise also that it was combined immediately with the fact that beginning September 15th, the providers will have to do a random time study of their staff's work at the same time when they're training new staff on the new procedures, protocols, caseloads, and reporting requirements. This is going to be very challenging, and the coalition is trying to do two things. We're trying to make sure that OMH is explaining to CMS that the challenges of doing the study simultaneously while training new staff and undergoing the transition is difficult and may impact the data. And we are requesting that OMH hold providers harmless from any takebacks that may result from the random time study. And so the next slide that I just put up shows the responses from OMH to date on the work, that I'm trying to do with them around these concerns. So the response about the challenge of doing the time and motion study being too overwhelming was that CMS has held OMH to the September start for the study because the signed off agreement with CMS between the state and CMS was that there would be 3 full months of data collection, and that they did relay to CMS the challenges and that the data and the outcomes of the study may be skewed because of the implementation of the new program. And when we communicated that now that the state has sent out worksheets and budget changes for the 1915C interim program, is the state guaranteeing those rates and going to absorb any disallowances that might be a result of the study? And the initial answer back, so this is new, even from our call earlier this week, is that they have reviewed and are continuing to review the language in the approved application for the 1915C waiver, and it does not reference reconciliation or recoupment at all. So OMH will go to DOH to get confirmation that that's the understanding that everyone has, which I think should make people feel a little bit better than where we were earlier this week. So I'll stop there and see if there are any questions.
I haven't gotten it yet, but folks feel free to raise your hand. And Lisa, I saw you got back on. I've unmuted you if you'd like to speak up. No?
Thank you, I'm all set.
Okay. All right, I think we can move on.
Okay. So I don't have a lot to report on the RTFs, unfortunately. We have had an ongoing problem with, since the rates went over to DOH, about getting interim reports on where the rate packages are for the RTFs and what the timing of the rate packages would be and what the preliminary rates for next year would be when the rate that was effective July 1st, 2017 would be forthcoming. I put in the request for all of that information to 5 or 6 people between OMH and DOH earlier, I think last week. And, the request is pending, but this is something that 2 years ago we took up with the governor's office, and we did get a very vocal promise from DOH that they would be responsive to our requests, and that hasn't materialized. So, it's disappointing that we're going to have to do that go around again. But it's also disappointing that, OMH staff as overwhelmed as they are unable to, have the authority to share whatever they get from DOH with us when they get it. It seems like there is a barrier. To me, the request should really be, if DOH shares it with OMH, OMH should be able to share it with us. I shouldn't have to wait until DOH, blows in the wind and feels like they have time to share it with us. So we'll be having that discussion again about how we're getting caught between the two agencies. And I apologize that the rate, information about the rates is not available at this time. And then, I think that probably we could open up the lines to any of the RTFs that have any more detail about their pilot applications and how they're feeling about whether the field office and the central office, the staff that are talking to you about those, are being responsive. But at least OMH is willing to, meet with the coalition and the board, which will have a meeting in October to talk about moving the work forward. So I think that we'll probably, Nicole, just see if anyone has anything to add about the RTF pilots.
Okay.
Andrea, this is Jim. I have a call with the regional office this afternoon. It's just to get some sense of what they're thinking. To remind everybody, I think it was early in the summer, the state kind of said if there's going, if we see there's a need for the RTF and vacancies are not an issue, they'll think differently about the pilots. So I don't know as if they know what they want to do anymore. I think we've pushed the whole census thing, and I think there's been some better move in many of the RTFs, but I think OMH doesn't really know what they're going to do with the pilots.
So I did unmute a couple folks if they'd like to comment back to Jim and Andrea. So I unmuted Jim Nyreen and Gerard McCaffrey. So please speak up.
Yeah, so this is Gerard McCaffrey. Just an FYI, we submitted for a waiver, but we have not had any follow-up contact with the regional office. So I will after we hang up, and I'll keep you posted.
Okay, thanks.
Thanks, Jerry.
Oh, and Jim can't actually use the audio, and he says, SCO Atali at RTF applied for pilot, but we've not heard anything from Central or the field office. Do we reach out to Central?
I would say, Jim, to reach out to the field office and say the central office is indicating that the field offices should be following up. And then that gives them the opportunity to find out what the direction is from central office. I want people that really feel like they want to transition their services to move forward on this. I think it's something that in the long term is important, but given the rapid pace of the transition plan and the fact that we're commenting on the point that kids with really high needs are going to be in a somewhat precarious situation during the transition, it does beg the question, Jim, to your point, is OMH rethinking the timing of all of this because there won't be a safety net for kids? It could be possible that the RTFs may need to be a safety net for some kids as the community services stretch out.
And I think it's also possible that the RTFs will never go into managed care.
That's not what the plan says.
I understand. And maybe they'll go in some kind of obscure way. Maybe they'll manage utilization, but, I think, some indications are that OMH doesn't really know what to do with the higher end services. I think day treatment is another example, but the RTFs, so I think we've got to stay on top of it. I think if you've got pilots, we want to push it help organizations that want to transform some of their services. But I don't know as if OMH knows what they're doing. I don't know if anybody has replaced Tara as the RTF person. Do we know if that's happened in the central office?
Yeah, it has happened. I'm completely blanking on who it is, but I asked for an organizational chart, and I will share that with all the. I will get an organizational chart for all of Donna and Meredith's staff out to all of our members as soon as possible. It's been requested. I haven't received it back, but that's a good point, a good reminder.
So I also have unmuted Lenny, and if you'd like to ask a question or make comments. Lenny? You're welcome to also type them in the questions box, and I can make your comments aloud. Teresa, I had a little feedback from you, but I'm going to unmute you. I see your hand is raised as well. Teresa?
Hi. Yeah, we've had questions from our regional office asking, because several of you know the pilot work, the new program we're looking at, but they actually want us to commit the beds without telling us who's going to license and fund those beds. So we're actually going to push out to state and ask for clarification, because that's what our region's asking when they haven't really been at the same level as Emma and Donna.
Yeah, it doesn't, I mean, just if people had trouble hearing Terry, it doesn't seem right that you should be figuring out how to license the program that's being proposed. That's what the technical assistance from the state was supposed to do, if I can paraphrase your comment.
Yes, you got that.
Yeah, tell us what you want to do, and tell us how we might want to.
How we can make it happen.
Right, and we might pay for it, or.
All right, so we'll try to work on getting some clarity, and I apologize. I should have worked up on this earlier in the summer. There was just so much else going on. I was under the impression that things were moving forward, but clearly not. So we will get more involved.
Yeah, I'll let people know what happens with the call. After I let our staff know.
Thanks, Jim. All right, on August 3rd, there was an announcement. We can always come back if people have other RTF comments, but on August 3rd, there was an announcement about how the reconciliation of the historic TCM transition to health home would take place. That DOH was developing kind of a template calculator for the period December 16th through March 17th. They were going to test it on 20 providers. They prioritized the 20 based on the surveys of those most likely to be eligible for a reconciliation payment. And then after they test it, if it seems like it produced the results that the providers were anticipating, they will pass on that budget request for the top 20 providers to DOB, and then they will apply it to the universe of 70 TCM providers. So if anyone has any feedback about where they feel that this is going and what their experience with the prototype template calculator was, I know that I talked to Rob Sisma from the Child Center, and he felt that the calculation looked accurate. I don't know if anyone else has any feedback.
Yeah, no, I think we also think it looked pretty good.
Hi, it's Lenny. Can you hear me?
Yep. Hi, Len.
Hi, sorry, I had trouble getting on before. I just, with regards to the RTFs, Jewish Board did have a call. We received, an arrangement to have a call with Donna and the regional office. But they, during the call, they wanted some specifics, real detail about the pilot, which, of course, they had not told us what the call was about. So we gave them what we could at the time. And the one interesting thing that did come up was I raised, the recent trend where we're starting to see referrals throughout some of the regions, and whether they had thought about, originally they had said to downsize by a full unit, whether there was some reconsideration of that. And I didn't really get a clear answer from anybody on the phone. And of note was that Emil was either on vacation, but he was not on the call, and they said they would have to get back to us once they could talk to Emil. So just some information about the process.
Thanks, Lynn. Yeah, this definitely seems budget driven, like the money can't be released unless it meets certain criteria, and that isn't going to be made on the program side. So we have to keep our eyes on that. So, it can go slowly. We don't need to move anything quickly, especially if the beds are full. For the providers who are still having bed vacancies, I understand the urgency of this.
Some more information for people, just, to let you know. I've talked to Emil about the gap between the RTC and the RTF are becoming smaller and smaller, particularly for those that have hard to place populations. And he spent a couple hours at Astor trying to understand the RTC budgeting and rate setting and the programmatic differences. He looked at our RTF, he looked at the RTC. We talked about, what we could do if a pilot, if they were interested. So I got the sense that they're still kind of trying to understand the whole residential system and see what might be possible.
Okay. Nicole, anything on either RTF or TCM?
I have a comment from Fern. She made a comment. This discussion reminds me that CDT was left out of the list with services in the draft and that adult services were included.
Right. I did make a comment about the adult services, and could they clarify how eligibility determinations for those services will be made and whether the kids system will be authorized to make those determinations. So that I did include, Fern.
Okay.
It's Lenny again. Can you hear me?
Yes.
Yeah, some of us have been looking at some of the data that you've put up, and it's interesting that when the RTF beds have the highest number, you see the lower number on the hospitalization end. So you see less hospitalizations as you see more RTF beds. Something to keep in mind.
Right.
Not that any of us are surprised or anything, but it's just interesting data that confirms what we all know.
Right. Thanks to Marlene. So, all right. So two other things that happened this summer. One more recent than the other, but we have them in the opposite on the PowerPoint presentation. The New York State Value-Based Readiness Program. This is the $60 million that OMH has available to invest in value-based readiness for behavioral health. The RFA was out. You had to respond by June 5th, and the state has released the list of lead agencies or the list of providers whose applications had merit. They determined that the applications had merit. And Nicole, if you could put up that Excel spreadsheet, which lists the lead agencies.
Okay. Here we go.
So you see a number of our members have successfully made the cut. Astor, Children's Home, Hillside, Citizen Advocate, Kids Oneida. I don't mean to leave anyone else out. But these proposals have been accepted to meet the minimum thresholds for consideration. However, my understanding is, and people can clarify if not, that most or all were approached and said they don't have enough money to fund all of these, so they hope that groups will figure out how to work together on the implementation of their plan. And you know, I guess I'll just leave it at that and see if anyone wants to add anything. Nicole, if you can take the list down. And I did send that list to everyone so that people are aware. But that list of agencies are the ones who will receive applications later this month.
All right, I do have a hand raised. Karen Richmond, do you have a question?
Hi, Karen.
We're not hearing you, Karen, so we're going to move forward.
You unmuted Karen, but she has to unmute herself, maybe.
You self-muted. Oh, okay. All right, we'll move forward. It must have been an accident.
Okay. All right. All right. And then the other announcement that came out this summer, and not that we were surprised, but we were not happy, was the list of hospitals, basically, and a few community providers that received the first round of the statewide health facility funding. A number of our members had spent significant amount of time on those applications, and they were not funded. But true to the legislature's directive, DOH did ask for stakeholder input about how the next round of statewide health facility funding should be utilized and what criteria should be used. And even though I said we'll share the screen, Nicole, we don't have to do it. I sent along to the members the letter that we submitted on how the next round should be evaluated. We urge that RTFs be eligible. Right now, only Article 31 licensed outpatient facilities are eligible. So we urge that other Article 31 licensed facilities like RTFs should be eligible. And we also urge that, and really at OMH's insistence that we do this, that clinics that predominantly serve children, clinics that are serving children and families in a way that make them essential to the community be another priority group, and clinics that are interested in integrating with pediatric practices be also considered priorities in terms of the next round. And we also urge that DOH work carefully with OMH in identifying those categories, the individual agencies within those categories based on their relationship with our provider community. And we hope that the next RFA will come out sometime later this fall. So if no one has any questions about that, I'll just move on to the announcement that our 2017 annual policy forum will focus on the First 1,000 Days initiative that Jason Helgerson mentioned shortly after he met with us. And I give a little description of this initiative. Many of our providers are appointed to the work group that is being chaired by the former SUNY Chancellor Nancy Zimpher, and Suzanne Brundage at United Hospital Fund is staffing the group along with Kate Breslin at SCAA. And a lot of these people are going to be at our policy forum. Jackie released the save the date on the policy forum recently, and we're real excited about a really high-powered group of speakers, including Jason Helgerson, and we hope that this event will be as well attended as it always is by our members. Any questions about that?
Haven't gotten any yet, but anyone feel free to raise your hand and or type in the questions box if you don't have access to audio. Oh, Steve Bolger, is there an opportunity for appointment to the 1,000 Days work group chaired by the Chancellor? And he doesn't have a microphone, so he can't respond back.
Yeah. You know, Steve, I had reached out to the governor's office after the announcement and asked about appointments, but they had done the appointments based on who was already on the Children's Clinical Advisory Group, and I don't think that there's an opportunity for any additional appointments. They are charged with putting together a 10-point plan by November 1st so that it can be incorporated into the executive budget request. So it's not as if we'll have opportunity to comment on the 10-point plan, but it's not as if they're going to be doing any additional appointments at this time.
And, you know, I was at an early intervention coordinating council meeting yesterday, and from DOH, they indicated this would almost operate the way the MRT did. Some fairly quick first round recommendations, but that's only going to be the beginning. So I think there may be other opportunities.
So we'll keep our eyes open for other opportunities. And we have one last item, an announcement. Okay. One last item, just reminding people that we open up the nominations for filling vacancies on the board in the fall so that we can vote at our December membership meeting on a slate of candidates. And Jackie, why don't you take this over from here?
Okay, great. We will have a few vacancies on the board of directors this year. We have 2 family members whose vacancies are up. So we really encourage our providers, if you have some family members that you'd like to have engaged with the coalition, to submit names. We will be sending something formal out once we convene the committee in the next week or so. In addition, we have a few board of directors whose terms are up, but they are eligible for re-election. There's about 3 of those, and we will have 1 slot, possibly 2 offered. One of our officers' terms are up, so we'll have to make, the board will have to make some decisions there. So just look for a email from Liz Nolan and myself within the next week or so, and we encourage you, if you're interested in participating, to put your name forward to the nominating committee, and then we will have our vote at the annual meeting of the corporation at the conference.
So that will be the process, that there'll be a vote at the annual meeting and that the new members would take their positions in January? Jackie?
Yes, Jim. This is Andrea. Yes, that's the process.
Okay.
January 1st is the effective date of the any new seats. Yeah.
I'm sorry, I just got disconnected. Yeah, it was January 1st is the effective date.
So that's the report that we had prepared for today. I know it's a little bit early. I don't know if anyone complains about ending a meeting early, but is there any other business that people would like to raise or questions that people have for the staff? We can open that up now, Nicole.
Yes, if any folks have any questions, feel free to raise your hand. I will unmute you, or if you want to type in the questions box. Nobody? I don't think we have any questions at this moment.
Jackie, could you talk a little bit about the conference timeframe, since we probably will be getting out material before our next coalition meeting, so that people make sure it's on their calendar, and any employee of the year information you want to give as well?
Okay, sure. Yep. The conference is scheduled for November 28th and 29th. Actually, this afternoon, our conference planning committee is meeting, and we'll be selecting the proposals. We had quite a few come in, so we thank the agencies for that. We'll be working after this afternoon, and we select our proposals. We'll be working on pulling together a brochure and agenda over the next couple of weeks. And at that time, the Employee of the Year Awards nominations will go out. Just as a reminder to agencies, it's one employee per program in your agency. So for example, if you had an RTF and a CR and a waiver program, your agency would be entitled to 3 employee awards, 1 for each of those. But we do not make exceptions to have 2 per program or per agency otherwise. We spoke to Donna Bradbury yesterday, and she's excited. She will be giving out the awards again. And I look forward to meeting with the committee this afternoon so that we can start pulling together the agenda.
Thank you.
And I just wanted to, this is Andrea, I just want to make a clarification. Care management, even though we know many of you have care managers, and I'm sure they're excellent employees, isn't actually a service program that is a dues-paying service program. So no care management nominees, please. Just because we don't want to make confusion around that, I think.
Okay, it sounds like, or seems like, there is no other comments or questions. Nicole, is that correct?
That is correct.
So I will, thank Andrea, Jackie, and Nicole for putting this together. I'll thank all the people who were able to make this meeting. There's a lot going on, and there's still a lot of things and questions that are being decided. So it's important that you know that your coalition is really representing your interests and has been a strong advocate for your needs. And that's number one. Number two, we have 2 important events, the Public Policy Forum and the Coalition Conference. And while we certainly want representatives from the agency, we encourage you, particularly the Public Policy Forum, to ask some of your government officials or some people who you have connections with to consider going, because it really is our opportunity to demonstrate what the coalition is doing. So I would certainly put a commercial for that. With that, I would say thank you, and everybody have a great weekend. Andrea, do you have anything else?
Nope, that's it. And just keep all of our friends and colleagues in Florida in your thoughts over the weekend, and hope that things go way better than they're predicted to.
Yes. Okay.
All right.
All right.
Take care.
Thank you.
Bye-bye.
Bye.
Thanks, Nicole. Yep, bye-bye.